Hi, everyone, and thank you for joining us for this version of the Thursday Talk. My name is Tracy Olston, and this is Dr. Charles Hunley, and we are with the Provider Partner. A lot of times we get questions about who is the Provider Partner? What are you guys doing for the future? How are you helping healthcare groups across the country? And the most important thing is, why did you decide to go into this? So, Dr. Hunley, would you like to give a brief introduction on why we decided to go into this?
Yeah, I definitely would love to. So, welcome everyone who's watching this. I know that we've had some Thursday talks in the past, and we're really starting to ramp up our conversation with the community and the healthcare community. About many years ago, when I was a young attending, I actually never got taught coding and billing. I never got taught how to document the way I was supposed to. As I became an attending, I fortunately had a couple of circumstances where I had some people who really introduced me to coding and billing in the sense of not just like making money, but how what I say on my charts make a difference. And the way I say them instead of just putting, on the charts. And then I, several things happened in my career that I realized that it's not just writing a chart and then putting a bill out there and they don't connect, but they're very interrelated. um, I ran across my partner, Tracy, and we basically started understanding that there is a disconnect between what we do clinically and what coding and billing do, and that there's a chasm, a gap of understanding. And anytime that there's a misunderstanding, there's a waste. And so we started out as our project, and we realized that by designing a process of understanding what the documentation, not just the CDI. I mean, if you hear CDI or code queries from any physician, they lose their mind. Most of them are like, those guys just send out queries, they're just useless. But what that really means, and what that means in the big scheme of things to the coders. And on the same side, on the coders, having them understand what the doctors are writing and the big concept. And so we started this project, and it ended up being a methodology, and not just that, a process to optimize not just physicians what they say, because if you ask in the beginning, the coders are like, the physicians just need to write this, and the physicians are like, I'm writing that. It's a process. And so we designed the provider partners as a partnership, not just to come in and tell people what to write, but to optimize their workflow and their environment, so and to have the coding that they intimately work with, and they don't even know they do, understand what they do. And so this process has evolved into the provider partners, which we are not a consulting firm. We consult, but we also, I call us an optimization organization. And part of the Thursday talks is to talk about things that affect workflow. So
So,
that's
what
kind
I
of
think
my
what I
introduction.
think is really interesting, Dr. Hunley, is I've worked in the medical industry almost 30 years, and every provider that I talk to, it's the same story across the board. They don't understand that their documentation interprets to the CPT codes that are chosen, and those CPT codes are directly linked to their work RVUs. And work RVUs are a lot of times used as a compensation model for physicians. So without a physician understanding, their documentation is really driving potentially how they get reimbursed. That actually has opened a lot of mindsets to physicians where they didn't understand that connection before between what they documented, what they coded, and how it relates to their overall compensation packages.
Yeah, and that's actually an interesting facet, an evolution in the sense that physicians, we think clinically all the time. And so um, I joke around and say, when you're at doctor's lounge, you're talking about a patient, you're talking about what you saw today, and we're all in the same mindset. So we all talk the same language. We all kind of know what's going on. Most physicians don't really, and it's not they don't make the connection, but they're in their, I call them in their microcosm. They don't realize that when people are reading charts and they're reading from the outside, that they don't have that big picture. They don't, I can say, as one of my colleagues is saying, we had a patient that had COPD with an exacerbation, and I'm thinking in my mind, because I've seen it so many times, all the sequelae. And so they're not putting in the chart, they're writing it for the physicians and the communication of the next physician. They're not realizing that, hey, I kind of need to be specific, because somebody who's not clinical is actually reading the charts, documenting what the CPT codes are, and et cetera, and they don't have that big picture. Part of the reason what we do is we take our coders, right, and they round with the physicians as the provider partners.
Mm-hmm.
And so they get that optimization of the workflow, and every workflow is a little bit different. I mean, we've had workflows where we had liver transplant centers, we've had workflow trauma centers, we've had workflow of urgent cares, and every clinical environment is a different picture how you can optimize your wording to have that severity of illness. And I'm not saying optimize is like cheating, but to be transparent and specific to the level of illness of that patient.
Well, and I think too, it's important to understand is a lot of physicians do this day in and day out. This is second nature to them.
Mhm.
Just like you're an intensivist, you probably do things every single day. I know I've shadowed with you. That's actually how we met. I was shadowing you. And you have done chest tubes and intubations and all sorts of procedures, central lines that are second nature because of what specialty that you practice. And so, without physicians and coders kind of connecting with one another, it's hard at times to recognize, what is something that is not status quo. Because you're doing things every single day. It's a lot of times, maybe you're putting in 6 or 7 chest tubes in one day. And for somebody to look at it and to shadow you with a outside perspective to say, hey, wait a minute, you're doing this procedure, make sure you document this because we want you to be able to get credit, just I think adds another layer of making sure providers are getting paid for what they're doing. It's
Yeah.
not it's not cheating the system. It's giving you credit where credit is due. Whereas maybe you don't understand that you're due credit because it's something that you do day in and day out.
Well, that's exactly it. I actually, when you were just talking about it, and I'm going to date myself. Um, there was a commercial from Dunkin' Donuts where the guy would get up in the middle of the morning and say, "Time to make the donuts," right? Well, the physician with their specialty, each day they go into that specialty, and whether it's a trauma surgeon that sees car, MVCs, which is motor vehicle collisions or motorcycle or gunshots or uh, standing and fall, they see it so often that they don't realize, you know, I'm using a trauma surgeon as an
Yeah.
example because the world, when you hear trauma, everybody kind of loses their minds. But the trauma surgeons have done it so often that their notes sometimes don't reflect how serious the patient are, because they're like, hey, I can't, MVC, now, and I'm going to use technically subdural hematoma secondary to injury with, a spinal fracture, and he has five different injuries, right? But to him, he did this last week, a week
Mhm.
before, and the injuries. And so sometimes physicians get into a habit of writing a note quickly because it's time to make the donuts. We need to move on.
Yeah.
And understanding that process of, hey, that does affect not just physician compensation. But in this world, I mean, as an administrator, I hope administrators actually understand us and what we do. My level of severity, by documenting my level of severity, it helps the DRGs for the hospital to get, and right now that's a very sticky situation in the country. I mean, I know many hospitals are under stress, and optimization of coding and documentation is extremely important for the survivability of the healthcare system.
Yeah. And that's really, I think, where our future is. Our future as a company is to help physicians get credit where it's due, but also to help those health systems and those hospitals that are struggling to make sure that they can also report out the appropriate DRG levels and those facility codes to make sure that they're getting the reimbursement for how sick the patient really is. Because a lot of hospitals go off of length of stay in comparison to the DRG with industry standards. And if your physician documentation doesn't have the requirements to show the overall severity of the patient, when it comes to billing the facility side, your DRGs are going to be dropped into a lower category
Mm-hmm.
where there's going to be no connection between any comorbidities or complications. But also on the physician side, when you are not specific enough, you run the risk of denials from the insurance carriers. So it's really a no-win situation for the facility and the physician on reimbursement unless physicians are coached as to, the documentation specifics and that getting your documentation to the highest level of specificity for the services that you are providing.
Yeah, and it's interesting you say that because um, we know that every institution. In fact, I just had this conversation with a, administrator of a very large institution, and um, they said we have our own CDI team. We have our own CDI team. We we get it. And I asked the administrator. I said, I want you to pull up your last 20 queries, right? Your last 20 queries, and
Yep.
see what they queried the physicians. See if they queried any documentation, or they just put out randomness of. And he was like, and I bet him actually, and I haven't repaid him yet, but I bet him a beer. I said, I will buy you a beer if, and I did the negative. So I said, if they did everything right, you owe me a beer, right? If
Yep.
I'll buy you a beer to show you that you're going to get queries like acute, you're going to get not just acute respiratory failure, but was this patient have cerebral edema? When they documented cerebral edema on the chart, but they didn't document the severity
Yep.
right, they didn't document what they documented. A word that was a random word that the CDI was looking for, right? Not the overall, picture of how sick this patient is. And it's interesting because he goes, I bet you, and he's a good friend of mine, and I went, and he goes, you're right, they're just like malnutrition. I'm like, yeah. And they're like, well, there was like 20 other problems, but they saw malnutrition. They
Yep.
saw, and I'm like, yeah, you know, if you look at the charts, the big picture of the whole documentation is really important, you know,
It is.
and that raises the DRG much better than just having some random person look for a word that's there. So, and
Well,
so
and
that's what we do.
I think too, a lot of times CDI professionals and coders are faced with a lot of copy paste issues with health systems. The electronic medical record has not done anybody any justice.
Mm-mm.
I have physicians that I am currently coaching that will copy paste everything from a prior day's note. They will not make any changes whatsoever. And it will say that the patient is healthy, that the patient is stabilized, But then you see in the orders where they have ordered, oxygen on the patient. We've got x-rays that are being ordered on the patient, back-to-back labs. But the note is reading as if the patient is improving and stable because they've copied and pasted it and not made the necessary changes for that 24-hour of care period. And so I think, a lot of times the coders and the CDI professionals, because now we have these handy dandy tools, especially with Epic, I can hover over a paragraph and see exactly who wrote it. And I think the providers are forgetting, because there is that provider shortage that is going on across the country. Providers' time is very limited. And let's get real. Every provider hates to document because of all the clicks and the buttons and the dot phrases and everything that they have to do. They went to school to be clinicians, not to do documentation. That the time being devoted nowadays to documentation is getting smaller and smaller and smaller, but the reimbursement for the documentation still remains the same.
Yeah, no, and that's part of like who we are. So the idea is to not just, it overall helps. What we do is, we have a process that goes in and analytically looks at individual documentation and group documentation. And
Yeah.
as you just said, we analyze this process with a clinician and a coding, not just coders coming in, but you have a clinician to go, how does this work? And a specialist in your area. Um, you know, Whether it's a surgeon, surgery or internal medicine, or hospitals or critical care, somebody
Yeah.
who understands your workflow. And then we optimize, and I say optimize because it takes a while, right? I mean, it takes you can't just come in and hand somebody a sheet and say go do this,
Yeah.
because
Absolutely.
it is I hate the term lean or IHA lean process kind of, hey, let's optimize, get the lowest hanging fruit, the highest change that you can make at first, and then get it. um, and it allows the physicians to not focus on the queries, the this, the that. It That's why, and once again, that's why we named our company the Provider Partners. We want
Yep.
to basically partner, and we should say, if we could name our name different, we'd like the Provider Partners for physicians and administrators. I mean, because to be honest with you, it all helps. But I just, in this state of healthcare, I just had a person say to me, you need three things in a hospital: you need patients, you need doctors, and you need nurses. You also need a lot of other stuff like RTs, etc. I'm not insulting anybody, but really, you need that efficiency of clinic to avoid burnout, to avoid doing things you don't want to do, you know.
Yeah.
So
So, if any of you are interested in learning more about the services that the provider partner can offer, please go ahead and reach out to us to www.theproviderpartner.com. We do offer a free assessment for those who are interested in seeing areas that they can optimize. So, we encourage all of you to reach out to us.
yeah,
Thanks and have a great day.
thank you.